Good evening, everybody. My name is Jenny Pearson. I'm a Professional Development Officer for the Primary Health Network. Welcome to our Chrysalis Wellbeing series, session number 5. Tonight, our topic is working with Aboriginal patients in a mental health and wellbeing context. And we have Dr. Anita Watts is our facilitator. Just before I do go any further, I'd like to acknowledge the traditional custodians of the land that we meet on tonight and pay respect to elders past, present and emerging. If you can all have your microphones on mute, that would be great. And if you have any questions, please type them into the question box and we'll endeavour to answer them all tonight. And at the end of the session, there will be a quick survey that will pop up. If you could just it'll only take 30 seconds just to complete it. Thanks, Anita. I'll hand over to you.
Thanks, Jenny. My name's Anita Watts. I'm an Aboriginal general practitioner. I'm working in Newcastle. I'd also like to acknowledge country. For me, that's a Wabakal country, and also to acknowledge all the lands that you're all on this evening and pay my respects to elders. Thanks for joining us for the webinar tonight. We've got 3 fantastic speakers. I'll introduce them all just before they speak, but just to let you know who they all are. Ray Kelly, Georgina Moore and Sally Ann Avery are our speakers tonight. As Jenny said, we'd like to encourage lots of questions. So if you type your questions into the chat box, into the question box as we go. So we might get started. Our first speaker is Ray Kelly. Ray is an exercise physiologist who is from Ray Kelly Fitness. He's going to be speaking to us about lifestyle interventions, data and evidence to improve mental health and wellbeing of Aboriginal patients. Thank you, Ray.
Cheers. So have I got the screen yet? There we go. Okay, thanks for making the time to come on tonight, guys. Hopefully this will be, we'll be able to supply you with some strategies to help improve treatments with your patients. I'd like to start by acknowledging the traditional owners of the land on which we're on. I'm originally from Gomeroi area, so up near Tamworth, Corindai, Wallabadar area, but I live on Darkined Young land these days and work all over the place. And I'd like to pay my respects to the elders past and present. This is my home. So this is from the Who'd Have Thought It lookout in Corindai. And it still gives me goosebumps looking there. My family's still all up there. So, you know, I love putting this at the start of my presentations, so that it's just a little reminder of country. Just a little bit about myself. I'm an accredited exercise physiologist. I was physiologist of the year last year with my work in regional and remote communities, masters in teaching, PDHPE, bachelor in research, and I'm doing a PhD on reversal of type 2 diabetes in community these days. I've been working in health for 29 years, going on 30 years, and I guess the early days I was working with the elite sport with the World Championships and Atlanta and Sydney Olympics, Institute of Sport. Trained a couple of winners on The Biggest Loser, worked on The Contender, published a couple of books and run a lot of chronic disease programs. So I've just been around for a while. So when we talk about patients that might have mental health issues or are looking to improve wellness, there's a bit of a general profile. And obviously this doesn't fit everyone, but this is a general sort of scope of a person that we might see in practice. So they might be withdrawn, poor eating habits. So, and that could range from not eating at all to, you know, sleeping all day and then eating late at night, or even just other issues with foods, with just not preparing foods and eating takeout all the time. Usually inactive, so not much exercise getting done, and that sort of ties in a lot with being withdrawn as well. And you know, this all leads to comorbidity. So we'll usually find that over time there'll be increased weight, twice the chance of, or 2 times the chance of getting high blood pressure and pre-diabetes or type 2 diabetes. So, you know, these are things that just really make the condition so much worse to deal with. and in the end, it can sort of become sort of like a chicken or the egg sort of scenario. Added to all of this, we can sort of be dealing with injury or pain, and that can be through being inactive, and the comorbidities. All these sorts of things can lead to, back pain, knee pain, ankle pain, injuries, plantar fasciitis, shin splints, all of these sort of things, and that sort of restricts the activities of daily living and sort of encourages less activity. The benefits of exercise, I always like to start with like at the hint at the top. It's not the calorie burning. Everyone always thinks of exercise as the calorie burning. I always say it's just an added bonus. If you looked at the calories that got burnt from exercise, you'd be depressed. But it's a bonus. But there's so many more benefits, and these are the ones that are more specific for people with mental health issues. So it is an accepted first line of treatment for some health issues like depression and anxiety. So it's the first thing that a health professional should be sort of pushing towards as someone might be identifying it as having some problems. But basically, we've got cognitive function, so increased blood flow, increased memory. I mean, just even the endorphins through there. But also, I want to touch on just type 3 diabetes. It's so basically Alzheimer's these days is getting coined as type 3 diabetes because what they're showing is that insulin resistance in the brain can lead to issues with function later on in life. So as we're getting people with type 2 diabetes at a younger age, they're living with that much more and getting greater degeneration. But improvements in self-esteem, which can obviously have an effect on behavior, whether it be exercise, diet, being withdrawn, and so on. And the mobilization of visceral fat. So when we talk about high blood pressure and high blood sugars, a lot of the issues around there come from storing fat around the organs. So just by simply exercising, we can assist in moving that fat away from that area. And I mean, there's a range of other ways that can help as well. And then we've got the improvements in heart and blood vessels. So the strength of the left ventricle. So we can eject more blood with every beat. So that's going to bring down your resting heart rate. With the blood vessels, they're able to open up a lot more. So blood pressure will drop pretty quick. And we often see blood pressure can reduce from very dangerous levels to healthy levels within 7 to 14 days. And I put food intake in there in a question mark because what we often see is if someone's exercising regularly, they usually will make better food choices. And I'm not saying that they're not going to overeat and they're not going to eat takeaway and things like that, but they'll certainly be more mindful of what they're eating. And there's so many other benefits, with activities of daily living. So when we start people just walking, and we find that's going to make it easier for them to get around the house, getting up and down off the floor, all that sort of things, tying shoelaces, which increases independence, and reducing stress increases socializing. So there's so many benefits there, and I guess a lot of people who work in health are usually sold on this already. Some of the barriers for Aboriginal people, racism. So we know that the Aboriginal Medical Service is an absolute godsend for Aboriginal people, and that was born out of racism in the health system. And whilst places like the education system and the health system are leading areas in change, there is still racism within our ranks, and so that's going to be a barrier for some Aboriginal people. We've done some research in Western Sydney where we've shown that fatalism is occurring with Aboriginal people and type 2 diabetes and illness in general, to be honest. So they feel that some people feel like it's just inevitable that they're going to end up with these sort of issues. And in turn, it starts coming from some health professionals as well, where they kind of expect people to do poorly, respond poorly to treatment, those sorts of things. Health literacy is a big issue because it's not to do with literacy in general, but health literacy itself. And that can affect patients right from the word go on, how they interpret the information provided to them. I mean, how often do you hear a health professional say, I've told them what to do, I've given them the information, but they just won't do it? Well, quite often I put that back with the health profession to consider, do they understand what they need to do? And one of the first questions I ask someone is, what are you going to do starting tomorrow? And if they can give me an accurate precise way they're going to change their life, then I know they understand. But if they say move more, well, I know they don't really understand what I'm saying. Family, cultural, and work commitments. And I did put them in that order because anyone that's worked with, especially Aboriginal women, looking after the family is the #1 job, and they will put their own health to the side for that. So we've got to sort of assist when we're giving advice. It's got to work in with family and cultural commitments. And one thing that's not considered a lot, but work commitments, a lot of programs run for Aboriginal people are during work hours. And so if you've got a job, you're limited to being able to attend. And that's come up in a fair bit of research around adherence and attendance to programs for Aboriginal people. And then depending on where you're located, consistent access to healthcare and or support. So, I work in a lot of regional remote areas. So locums are, are traveling in and out, changeover of doctors. So they're less likely to want to change medications or make any changes overall, even with referrals. Staff turnover within a medical centre, no matter where you are, waiting list for specialists, geographical location, so travelling for access if you don't have a car or public transport. There's quite a range of barriers that can stand in the way of an Aboriginal person actually getting help. But your options, you can refer to an exercise physiologist like myself, under a care plan. So item 10953 you can get 5 to 10 visits as part of a team care arrangement. You also got the group exercise sessions or group sessions for those with type 2 diabetes as well. And I'd really encourage you to have a look at which item numbers are available for you. But there's other local lifestyle programs you might find, and they might be aqua aerobics and things like that. But just really find out what your patient enjoys doing and encourage that. It might be touch footy, it might be just shooting hoops with their son. It could be any range of things. But also don't forget some of the local groups like the cultural groups and men's sheds and everything. So it could be a weaving group, a dance group. It could be any range of things, but getting people out and moving can take a range of forms. But if that's not an option, you can sort of get people to walk around the street. So start off by walking around the block once, and then get them to build up to twice, and so on. And then, if they get motivated or they've got a good base level of fitness, they can walk for 2 light poles and jog for 1 light pole, and so on. A lot of people have come across that one over the years. With parks, they might want to go and throw the footy with their kids, or kick a ball, walk the dog. And even with the house, so we get some patients sometimes that really have trouble leaving the house. So we start them by walking up and down the hallway. And I'll never forget this lady I saw once who really struggled to get out of the house, and she was only coming out of the house to see me. And she was she started walking up and down the hallway, and then in no time she was actually walking 4 or 5 Ks a day. And then obviously things that can be done in the yard, little circuits. Just finally, I wanted to go over a quick case study of Margot, who was an interesting case I came across 3 years ago, who had her husband had died 12 months prior, and she quit work. She was 59, depression, poorly managed type 2 diabetes and blood pressure. So blood pressure was off the charts, and she was seeing a cardiologist, a nephrologist, and so on. Type 2 diabetes, her sugars ranged from 3 to 17, and she was on 4 to 5 injections a day. Poor sleep, so she slept all day and awake all night, and was overwhelmed by the health condition. She was just pretty much at her wit's end and just didn't know where to start to fix it all. She'd mentioned she was planning her own funeral, so her kids didn't have to worry about that. And she couldn't walk up steps. She just had a ramp put in, and she was shopping for a mobility cart. Now, she was not in a good way, but in 4 weeks, she was walking 4 kilometers a day, 7 days a week. In 8 weeks, she was starting to do little jogs on her own. I didn't tell her to. She just started doing it. I had to get her to pull back a bit. So, what I've found working as a physiologist is people with mental health issues and conditions can actually be pretty motivated once they get that foundation going. So the trick is to just try and get them started on something. And if you can get them motivated, find out what interests them and get them moving, and it could be just something as simple as walking, then you'll find that quite often people will self-motivate and get themselves out and going again. Thanks, guys.
Thanks, Ray, for sharing your expertise and experience with us. That was great. It's really useful to hear about some of the barriers to exercise for Aboriginal people and those really specific tips for how to engage our Aboriginal and Torres Strait Islander patients were really great. Thank you. As we said before, if you've got questions, pop them up onto the question box. We're going to hold off questions till all of our three presenters have finished their presentations. But at any time you can pop questions in. So our next speaker is Sally Avery. Sally is the manager of Aboriginal Drug and Alcohol Services for the Central Coast LHD, and she's going to be discussing how the Aboriginal social and emotional wellbeing model, as well as how to provide a safe environment to engage with Aboriginal patients and connect them with appropriate services. Thank you, Sally.
Thank you for having me. So I'm Sally Avery. I'm obviously the manager of Aboriginal Drug and Alcohol. Traditionally, I'm a Biripi woman from Port Macquarie. I've spent a lot of time in Kempsey and Port Macquarie growing up, but now located in Darkinjung country. So I'll be presenting today on Aboriginal social and emotional wellbeing model, which is a lot of the stuff that New South Wales Health has recently come out with dealing with Aboriginal mental health. So first, I'd also like to acknowledge the country that I'm on, the Darkinjung country, and pay my respects to elders both past, present and emerging. I would also like to acknowledge that this week is Reconciliation Week from May 27th to June 3rd, with the understanding that reconciliation is a national commitment to healing and the inclusion of First Nations people. So, like I said, the New South Wales Ministry has just come out with a strategy from 2020 to 2025, and it's been developed by Professor Pat Dudgeon, who's the first Aboriginal psychologist, along with some other people through New South Wales Health. So the social and emotional wellbeing is widely understood by Aboriginal people as physical, mental and spiritual wellness. And social and emotional wellbeing is like the holistic view of health. So the importance of connection to country, culture, spirituality, ancestry, family and community, and how these affect the individual. Yes.
Sorry, Sally, it's Jenny. We just can't see you and we can't see your presentation.
Okay. Can you see me now?
I can see your presentation now, but I can't see you.
Okay. Sorry, just bear with me 1 second.
No worries at all.
It won't let me. Okay, sorry. I think it's there.
Yes, that's it.
Okay, awesome. Sorry about that.
No worries at all.
Okay. But I can't. Okay. Sorry, it won't be a second. I just got to sort my view out myself. And the holistic view incorporates mental health. So I sort of mirror what Ray has just said about exercise and connection to country and culture being the most important thing for Aboriginal people when it comes to mental health and that holistic view of health. So with the social and emotional wellbeing model, it's about healing and strengthening the connections between Aboriginal people and their culture, and increasing that holistic model of health, and not a patient-centered model. Patient-centered is very individual for what the goal is for that client. Holistic is more about their physical, emotional connection to country and connection to culture. And for Aboriginal people, if you don't have a connection to your country or your culture, you're not going to be holistically well, because you'll be missing that spirituality of that connection. So this is the model that has been developed, and I'll go through each section to just discuss what each section is about. So obviously the connection to physical wellbeing is physical health, chronic disease, and other illnesses that somebody may have. The connection to mental health wellbeing is obviously how they're feeling in their mental state. Connection to family and kinship, whether they do have that connection with their family, or if their family has been transgenerationally affected by some of the stolen generations and other forms of trauma that Aboriginal people have faced. The connection to the community is about the connection to their local Aboriginal community. So whether they're linked in with their cultural groups, or whether they know people within that community. Sometimes this community, their Aboriginal community, may not be the community they're living in. It may be another community. So like I said, for myself, my home is Port Macquarie. So I do see that as my community as well, although I am connected in the community I currently live in now. So some Aboriginal people may have multiple communities which they're connected to. Connection to culture, like I said, and connection to the land, and connection to the spirituality and ancestors. So when it comes to those things, and a lot of our culture has been lost over the years. And so there's a lot of other different tools if somebody's not willing to engage with somebody in the community or attend a community group. There's a lot of online tools that you can learn culture and watch some videos about culture on, just to get an Aboriginal person started and interested into what area of their culture they'd like to learn and participate in. So like I said, it's more about just getting back to the basics. So water, nutritious food, limited processed foods, because our bodies were not made for processed foods, exercise, good sleep quality, self-care, and not meaning go to day spas or anything like that, more healing and knowing what your traumas are, so you're able to heal from them, shelter, abstinence from drug and alcohol, community connections, feeling a part of the mob, and connection to family. So also connection to country. You can go outside and just take your shoes off and be grounded into the country that you're standing on, or look up at the sky and take some deep breaths and feel better as an Aboriginal person. So it's just keeping Aboriginal people connected to their culture in a productive way. So some tips for working with Aboriginal people: acknowledge the resilience of Aboriginal people when they share their story. Understand the significance of culture, family, community, country, spirituality in their journey. Be mindful that some Aboriginal communities do have strict protocols when discussing men's or women's business, and that could also be a barrier when discussing some mental health or comorbidity issues. If it is identified that an Aboriginal person has been affected by the stolen generation, it's really important to give them some information about connecting with Link Up, because they're able to source like family histories from stolen generations and engage them with the Link Up for them to their mob or their family. And social and emotional wellbeing is a more acceptable term than mental health problems. As soon as someone says mental health issues, Aboriginal people are sort of like, oh no, I'm fine. Like it's more about the holistic view of that person. So social and emotional wellbeing is a lot more accepted in our community. And when an Aboriginal person refers to home, it's not their physical home, it's obviously the country that they come from and the mob that they are connected with. And when Aboriginal people talk about family members, cousins, sisters, brothers, uncles, aunties, nans and pops, it could be extended family members, friends that we've grown up with, or grown up alongside. So when it comes to medications and psychology, medications and psychology do obviously play a role in Aboriginal social and emotional wellbeing, but when it's absolutely necessary, because it's important to understand that many Aboriginal people won't be compliant with medications. They may take it for a week or two and then might go to a different country to visit family, forget their medications, not continue to take them, be non-compliant, or just not go and get a script filled. And a lot of Aboriginal people will think that taking a medication every day means that they're unwell, and that might make them feel more unwell by taking this particular medication every day. So if medication is needed, it's very important to explain why that medication is needed, and explain it in a way that's not so stigmatized. For example, if it's for like depression or anxiety, you could just say like, this will help you not be so stressed, or this will help you be able to cope with your family's needs a little bit better, rather than, oh, you have depression, you need to take this antidepressant. Obviously, you can say that at the end of explaining in a different way why that medication would be beneficial, but it's also good to explain it without the stigma involved. And psychology, obviously, if you could explain it as ways to deal with problems more effectively, so those skills can be passed on to the next generation. Aboriginal people are more inclined to try something if they know it's going to better their family, and they know it's going to better the generations after them. So it takes the stigma away. And there is a whole list of places and tools to support Aboriginal people that I've come up with here. So there's Wellmob, the ACI have a lot of resources. You can always look at the resources and toolkits on the AHMRC website. The local Aboriginal Land Council, if you don't know where to start or what groups or organisations are in your area. Local AMSs, Link Up, like I said before. Chase the Energy has a great movement on Instagram and Facebook at the moment about encouraging Aboriginal people to talk about mental health and physical exercise and not taking the stigma away from that. So that's a great page to follow. And then ADAN's Drug and Alcohol Rehab, Aboriginal Drug and Alcohol Rehab, any Aboriginal health unit in your area or local LHD, Aboriginal health workers across the region. Even if you're not from that area, you can reach out to an Aboriginal health worker and will generally know somebody from another area that we could link in with or give some advice about another area too or service. I've got networks throughout all of New South Wales, and I work on the Central Coast, so I'm sure that's the same for a lot of my other colleagues that work in Aboriginal health. And then there's also the Get Healthy program, which they've also just put on 10 free counselling sessions for Aboriginal people that are struggling with any alcohol misuse. And Your Room has a lot of drug and alcohol references and tools and resources as well. So they're all my references. Thank you.
Great, thank you so much. That was excellent, Sally. It's great to hear about all those enablers of good health, that keep us healthy, like, connection to country and all those positive things that are really important, connection to community. That was great. If the audience has any questions, type them into the question box, but we're going to hold off questions to the end of all three of the speakers. So I will introduce our next speaker. Our next speaker is Georgina Moore. Georgina is the Mental Health Nurse Unit Manager of Indigenous Health at Brisbane Waters Private Hospital at Woy. Georgina is going to discuss culturally safe language, screening tools and transition of care between practice and mental health services. Thanks, Georgina.
Hi everyone, thanks for having me. First of all, I'd like to acknowledge all the traditional owners of all the various lands we're sitting on today and pay respects to elders past and present. I'd also like to acknowledge the significance of yesterday's Sorry Day, and also tomorrow is White Reef Day, which is acknowledgement of those we've lost and impacted by suicide. Just a little bit quickly about me. I'm a registered nurse that's been working in mainly tertiary acute mental health and drug and alcohol services for a long time, 15, 20 years. I'm currently on the Central Coast and managing a private hospital, and also worked in AMS, worked alongside a lot of health professionals and GPs. So I think a lot of my presentation today is coming from the aspect of what I see about the how to work with Aboriginal people, and particularly I come from the lens of those presenting with more acute comorbidities like mental health and drug and alcohol. Next slide, please. So why is this important? If we actually look at the statistics, which a lot of us know, hang on, can't read my thing. Oh, which a lot of us, which a lot of us know, of course, we have high incidences of, sorry, I just can't see my, Indigenous, we have high incidences. Indigenous men, Aboriginal men have a rate 4.5 times higher than non-Aboriginal men, and same with the, Aboriginal women. We also have high levels of psychological distress, and this is very much on the background of the trauma we've experienced, which I'll go into later. Most of us know the suicide rate for Aboriginal people across all age groups is pretty much doubled. And also for young people 15 to 19 years, which is a big concern. We also have a much higher rate of illicit substance use, and 43% report lifetime use of illicit substance use. We're overrepresented in inpatient mental health services as well as forensic services, which we know. What we find is the most common mental health conditions requiring hospitalisation are substance-induced mental and behavioural disorders, 36%, schizophrenia spectrum and other psychotic disorders, which could be related to the illicit substance use, and depressive and bipolar disorders and anxiety disorders. Next slide. In my local area, I was at a local health district conference the other day, and most Aboriginal people that present to mental health services, 88% also present with comorbidity of drug and alcohol issues. So I think the trick for us as clinicians is how we work with both mental health and significant substance issues going on at the same time. A lot of the contributing factors, which both Ray and Sally have touched on, so I'll do it really briefly, is due to the history of Aboriginal people. We've seen a destruction of social infrastructure, we've seen rapid urbanisation and poverty, cultural, spiritual, emotional alienation, loss of identity, family dislocation, increased drug and alcohol. My grandma is a descendant of the Gringai mob and was stolen generation, so we have a large and really recent history of people having a breakdown of identity and sense of home and culture and family, which for anyone with mental health issues contributes significantly to some major disorders. Next slide, please. So I think in my practice, I think one of the most effective ways to work with people presenting with these comorbidities, and I see them in primary health a lot, and clinicians not knowing how to link them in with services or how to work with them. It's basic stuff, but it's quite complicated stuff at the end of the day too, is to come in with it from a trauma lens. I think trauma-informed care is the base of understanding that a significant number of people living with mental health conditions have experienced trauma in their lives. And maybe people in distress, the impact of trauma may be lifelong. Most Aboriginal people that walk through your door either have trauma significant to their life and their existence, or it's intergenerational and passed on throughout their family. So it's really important, I think, we do a trauma-informed practice. Sal touched on this again, to have a strength-based approach framework, grounded in the understanding of responsiveness to the impact of that trauma, and emphasise physical, psychological and emotional safety. It can create opportunities for survivors to rebuild a sense of control and empowerment. I've actually just come down from a Closing the Gap conference, and an Aboriginal elder and a GP had a beautiful quote that I want to share, that when you're working with these people, I think it's really important to leave your clinical at the door and bring your humanity into the room. And I think when you can sit there with a human alongside another human who's experienced a lot of trauma and listen to their story and respect their story, I think that's where you'll make a lot of groundwork. Next slide, please. So just some of the basics is where I find clinicians, they get a little scared about non-Aboriginal clinicians, or even Aboriginal clinicians that don't have a lot of connection to their culture, about a lot of the language that's used. And sometimes the language can be a really fun way of engaging and warming and at least acknowledging some respect to Aboriginal people. We've all heard the term yarning, you know, how about we sit down and have a yarn? It's a really culturally appropriate way to connect. It can help exchange information, and it's about sharing of stories. Having a yarn with Aboriginal people, we're very narrative based. We love the storytelling. So it's a really good way of getting the information. As I said, sit down, have a yarn, have a chat. You'll get a lot of information that way. Familiarise yourself with their specific community. A lot of us might be off country or from different communities or identify with different communities, so just ask the question. Be proactive in engaging with the local Aboriginal community, come into them, show your presence at various events. We put a lot of events on. It's a really good way to earn that engagement and respect. Strength-based approach, again, as Sal said, in the social emotional wellbeing context. Move away from a deficit model and try and acknowledge resilience, success and strength. We've survived, we're still here, so the acknowledgement of that can really help engagement. Appropriate language is really important. Medical terminology can really put a barrier into working with Aboriginal people. A really easy one is sometimes medically we talk about a podiatrist. Use the term foot doctor and they'll understand that better. So just use appropriate language that they'll understand, and just realise that literacy levels might be low as well. We had quite a complex drug and alcohol mental health Aboriginal woman. She had a lot of heart problems. She didn't understand the written information, but we showed her a picture of the heart and we used colours and we used drawings, and she absolutely understood what we were doing. So maybe look outside the box of giving that written information and use pictures and other ways of explaining some medical information. Mirror their body language. Sometimes eye-to-eye contact, and that is disrespectful with certain Aboriginal people in certain cultures. So just be mindful that the way their body language is showing might be a sign of respect, and to just be respectful of that. And as Sal related to also just some of the cultural protocols, be respectful to elders or family members. And for health workers too, just be mindful that for some topics, particularly sexual reproduction topics, things like that, there's men's and women's business. So a young boy might not talk to, or a male might not talk to a female clinician about certain things going on with them. So just be mindful that men and women's business is also involved. Next slide, please. Just some of the fun stuff, some of the Aboriginal words. It's not too scary. If you ask any Aboriginal person, they'll explain some of it to you. But there's certain ways they reference their Aboriginal identity. There's some of them up there: Guri, Kuri, Murri, Nunga, Noongar, and it's from various areas they're from. So that's just some of the words. It's good to familiarise yourself with some of that language. So when you talk to them or they talk to you, you understand what they're referring to. Next slide has a little bit more. Avoid using the word Aborigines. It's offensive. It's Aboriginal people, and the term just Indigenous in itself is not specific. So Indigenous Australians, Indigenous Aboriginal people is really important. I'm going to throw another one in there from young people. They use the word deadly. Deadly just kind of means cool, awesome. It doesn't mean deadly as in dead in the way some people refer to it. The term auntie and uncle is an elder in Aboriginal communities too. It's not necessarily blood related. Country refers to the particular defined area of land. A really good way is saying what country you're from, who's your mob. Mob is down there further. Just opening up the conversation, we've done it with some of that means you're respecting and trying to understand where they're coming from. Sorry business, grieving process and cultural protocols surrounding the death of a person. Just be aware of that and ask how the person might conduct that. And nation and tribe refers to a distinct group of people associated with a particular culturally defined area of land of country. So sometimes using some of that terminology and opening up that conversation can engage Aboriginal people. Next slide, please. For drug and alcohol, we have a case study a little later on, but talking about comorbidity, These are the easy ones. Grog, charge, booze, drink or piss are often the words for alcohol, and yandi or ganja is marijuana. Words not to be used in this there's a health document, New South Wales health document, where this is beautifully and clearly said. So if you want to refer to that, it's a great resource. ATSI is not a word to use. Native, mixed blood, half caste, quarter caste, full blood, part Aboriginal, 25%, 50% Aboriginal, then they. If we're Aboriginal, we're Aboriginal. It's not are you a quarter, are you half? It's quite offensive. Next slide, please. Asked to talk about screening tools and assessments. Again, as I've gone into the narrative and the kind of yarning, I just avoid going through the real clinical questioning. Have a chat, best way to open it up. A three-way yarn can be really useful, so particularly if you're working with younger people or there's certain elders or stuff in the room or community members, a three-way yarn's good. So the person themselves might not talk, but the elder, the family member, or the other person in the room might. So it's okay to elicit some of the conversation out of them and invite them into the room. The concept of family, as Sal's touched on, is really, really important. So I know in a lot of medicine we talk about confidentiality and stuff and just talking to the person, but the concept of family is really strong for Aboriginal people. So inviting them into the room might be a useful tool. Including them in the care is a really useful tool. Social emotional wellbeing concept Sal spoke about. The cultural appropriateness of symptoms. So just I've seen when we talk about psychosis and things like that, in some parts Aboriginal culture, sometimes hearing the voices of deceased family members is actually a cultural response. It doesn't necessarily mean the person's psychotic. So if you are doing a mental state exam or something like that and you're hearing things like that, just check out that it's not part of what goes on for the person culturally, and it's not actually a significant mental health disorder. Consultation and engagement may take time. Don't push them. At a trauma lens, having that yarn, engaging the family, set aside a bit of time, listen, acknowledge, be patient, give them the time to be heard and to speak. The mental state exam, of course, it's a basic one. It's a really good tool, but again, don't dot point it. Put it in a yarn, put it in a conversation, let the person just explore, make it a really natural process. They'll become much more at ease with you. And sometimes you might have to have more than one appointment to get some of that information. There is a tool, the Indigenous Risk Impact Screener, that can be used. That's on the next slide, which I'll get to. So if you can see some of that, it's just the wording's just a bit more kind of relaxed. So if you're welcome to grab that tool, you can find it online very easily. And it's just a bit of, it's not the K10s and the DAS and all those things we use. I tend to ask, do they want me to go through it with them? Sometimes they prefer that. Again, be aware of low literacy sometimes. That sometimes when we pass on tools and questionnaires and stuff, they don't understand it, or they don't want to answer it, or they can't read it. Sometimes there's a lot of shame associated with stuff as well. So again, don't throw a tool at them if they're not engaged and they're not comfortable. Just give them time, and of course use the family members or the people in the room. Another good tool, if you don't have access to that, is to use the Aboriginal health workers. I know definitely in our community on the Central Coast, sometimes the Aboriginal health workers have a lot of information over our Aboriginal people, and with consent are happy to sit in the room and work with you to explain what's going on for the person if the person doesn't want to open up to that themselves. I think we've got to remember there's a big background of systemic abuse for Aboriginal people and racism that came from systems such as child protection and health and churches and things like that. So sometimes they're very wary, very anxious about giving across information. If you can pull in family members, trusted people, Aboriginal health workers, often you can get that engagement and get that conversation happening much better. Next slide, please. Transition of care. Once you've got the information and you're thinking what to do, where to link them in. A collaborative approach is absolutely key, particularly with comorbidity. I know our system often silos mental health and drug and alcohol, but we do have Aboriginal managers and Aboriginal health workers in most of our various systems, particularly in health and in primary health as well. Pull in those people, speak to those people, do it as a collaborative approach. Again, that holistic view of healthcare. Don't try to treat just one component, treat the whole individual, treat them holistically. And that includes, in that little example I've got there, of combining all of it, their health, wellbeing and their empowerment, using the evidence-based intervention that we know that works and the treatments, understanding their Aboriginal worldview with that trauma lens and what's going on with them, and doing that strength-based approach of recovery, what works, they're resilient, and what works for them. If you can do a holistic treatment plan for them like that, which does take time, but it has much better outcomes and much better engagement for them. Try and find out local links with local Aboriginal services and consultants. Find Aboriginal health workers where you can, or find the Aboriginal health components of the health system. If you can't, at least find people that have a cultural safety and awareness that can work with Aboriginal people really well. Collaboration is absolutely key in integrating all the parts. It's a holistic model that we understand the most. That's it. Thank you.
Thanks, Georgina. That was absolutely awesome. Very much information in that talk, and all of it very, very useful. Thank you. I might ask all the presenters to put their cameras and their microphones on, because we've got a little bit of time for a few questions, I think, before we do the case presentation. Is that right? I think that's right. Everybody. Great. Welcome back, presenters. So I might just start with a question which I might address to Ray first. So I know, Ray, you are an Aboriginal man who is working in a service that I imagine is very welcoming to Aboriginal and Torres Strait Islander people. But have you got any tips for those of us who might be working in mainstream services about how to make our services more welcoming to Aboriginal and Torres Strait Islander people?
Yeah, no, it's a good question. And I guess one thing I will say is that Aboriginal people in general are pretty sensitive to this kind of thing. You know, that we can see if it's tokenism, like say if it's just sort of a bit of dot art on the wall but nothing else. I'll tell you, one of the best things you can do is have an Aboriginal person working there. That's pretty good. Like, that's seriously something. I'll never forget the first time I came down to the Central Coast, to Yeren, and saw Yama on the front counter there when I walked in, and like, I'm Gomeroi, Yama's my language too, and I just had an instant connection as soon as I walked in there. So you'll find it'll be the subtle things, but yeah, look, it can be tough, but what you'll find is Aboriginal people are there, like they're there, like a lot of the times they're coming to the table, and they're always coming to the table. So it's just a matter of the medical service actually doing something productive rather than just sort of something to be seen as doing it. And I'm not saying that that's what people do, but some people do. So, you know, just think more about what you might be able to offer, you know, the patients that are coming in.
Great, thanks. Georgina, did you have anything to add to that?
Yeah, I'd have to agree with Ray, actually. I think just be aware of the tokenism, just for services and clinicians to be just aware of their own underlying racism that most might go on, or their own opinions, and just be honest about it. Just be the truth and ask the people to walk through the door, I think.
Sally, my next question is going to be to you. In your talk, you mentioned, you know, some of the protocols about the Aboriginal and Torres Strait Islander people. Have you got any advice for if people are working in a community and they're not really sure what the protocols are, about where to get advice and how to go about not offending anybody?
So first of all, like obviously Aboriginal people have been through a lot of trauma. So just treating them with dignity and respect, and the way that we feel like we pick up on a bad vibe. We can pick up if somebody's judging us as soon as we walk in a room. So it's not being scared to ask the questions, as Georgie said, like call an Aboriginal medical service or call an Aboriginal health worker and ask what is okay in that community if you're not sure, or even ask the Aboriginal person. Just say, I'm new to this area. Is there anything I need to be mindful of? I want to respect your traditions and I want to respect you as an Aboriginal person. Is there anything that I need to be aware of? Just naming it sometimes rather than being so worried and you know, avoiding it can really help with the engagement.
Thanks. And Georgina, have you got any advice or tips that people do get it wrong? So if people, you know, do use the wrong language or use the wrong body language, what are tips for if you get it wrong?
Just be honest about it. As Sal says, how do I do it without swearing? They can smell BS. You know what I mean? Just be honest about it and go, look, sorry, I used the wrong word. I don't really understand. Can you teach me here? You know, Aboriginal people haven't been heard or acknowledged for a long time. Ask the question. They want to talk. They want to teach. They want to teach their culture. They're happy to hand the information over.
Mm.
And listen, like actually listen.
And listen, yeah, very important.
Great. Yeah. We might, unless you guys have anything else to add, move on to the case presentation and then take it from there. Is that all right if we move on to the case?
I think too, when I have like aunties or some elders come into a service, it's always good to offer like a drink, or would you like a tea or coffee? Do you need a water? That's respectful in itself as well.
Great. Okay, so we're going to move on to the case, and then there'll be time for some more discussion after the case. So can I actually have the next slide? Great, thank you. So the case is Josh. He's an 18-year-old man. He's in his final year, year 12 of high school. He's living in Newcastle with his mum, his dad, his brother, his 16-year-old brother. And his family moved to Newcastle from Tamworth 2 years ago for his dad's work with a local Aboriginal organisation. The family are Kamilaroi, and they have really strong connections to both the Newcastle and the Tamworth communities. Josh has been a high achieving student and he wants to study physiotherapy at university next year. He's very involved in sport. He comes in today with his parents and they are worried about him. They're worried that he's going off the rails. He's lost his focus on his schoolwork and on his sport. He seems withdrawn, he's not sleeping, he's not eating well, and he seems stressed out all the time. When he comes home, he's smelling of cigarettes and grog, and his parents think they're worried that he's fallen in with the wrong crowd, and they're suspecting that he's been smoking some Yandi. Next slide, please. So the other piece of information about Josh is that his grandpa, who he was very close to, died in Tamworth just a few months back. The family are now travelling to Tamworth most weekends to support Josh's nana and the rest of the family. Nan's got chronic kidney disease and she's going to hospital 3 days a week for treatment for dialysis for her chronic kidney disease. So if anybody's got questions from the background, from home, just feel free to stick them into the question box. But did any of you panellists have any further questions that you wanted to ask about Josh before we start chatting about an approach? No. So I might start with you, Ray. What would be Josh? You're on mute, Ray.
There we go. Well, I mean, if we look at the strengths of the situation, we know that, you know, his dad is working in Indigenous organisations, so there's certainly connection through there, but strong connections also through the communities in Newcastle and Tamworth, which are very strong Indigenous communities. So that there's a lot to be worked around through there. You know, I'd be sort of wondering whether there might be something happening at school. That could be definitely, obviously, the grandparent situation is going to be a contributing factor, but sometimes kids might become more focused in schoolwork. But if school's falling away as well, that might have been the one thing he had, and with it falling away, that's going to be something that's going to be pretty hard for him to pull back on. So I guess I'd be speaking to him first, like, you know, I'll be trying to get a connection with him first, and see if we can sort of get some dialogue going and finding out what he sees as the situation, but through there, trying to connect him with a group that might be of interest in him. He likes his sport. There's lots of sporting organisations. He's looking at going to uni, you know, getting in touch with Wallatuka at Newcastle University, and maybe organising for him to see what life might be like next year if he can sort of get focus. But I guess the main thing is trying to hear from him and find out what the issue is.
Yeah, thanks. Sally Ann, what would be your approach to him?
Yeah, so like Ray said, I would obviously I'd probably link him with an Aboriginal male worker to discuss any issues that he may be having, because obviously teenagers have all sorts of issues and it could be men's business. But if there wasn't a male worker, obviously I would explore it. I would link him with the NRL school program that they have for Indigenous kids, and if they're doing well in school, they get tickets to NRL games and things like that. They usually have an Aboriginal worker throughout Central Coast and the Hunter, and I would just obviously give him some education about Yandi and also to his sense of role within the family while his parents are trying to look after the family member that is not well. Maybe just have a discussion with him that it is time for him to, you know, take that role on and be a responsible member of the family and take that leadership on board. And sometimes when you go in with a family sense of direction, people are a little bit more open to changing their ways.
So like sort of building leadership sort of skills in him, you mean, like as it's responsibility?
Yeah, as an Aboriginal boy, and that he's turning into a man, and that it's time for him now to be there to support his family while they're going home to help with the nan. And he really needs, even though it's really hard for him what's going on at the moment, he really needs to be able to move forward and take that responsibility on as an Aboriginal man and a respected person in his community.
Jana?
I would approach it from the point of view, first of all, I want to know if Josh sees that anything's wrong, that he's got an issue. He might not see that anything's wrong. It might be normal stuff to him, and the concern might be coming from the family. I think then if the concern's coming from the family, I'd want to have a chat to the family. Going off the rails, what does that mean? What's the change look like? How long's it been? I'd also want to look at how the family's coping with the recent sorry business that's gone on in the family, what's going on. Because perhaps if the family system itself isn't coping, it might be Josh's reaction to that. I think if Josh sees that there's issues going on for him, then you've got some motivation and stuff to move. But if he sees that there's nothing wrong and the concern's coming from the family, then I'd be working with the family.
And Ray, how would you approach with Josh, you know, sort of trying to work out whether there are any safety issues going on for him at present in terms of his social and emotional well-being?
Yeah, well, yeah, it would depend on whether we could get him speaking. The first thing is trying to talk to him and trying to get that engagement, and you know, it's trying to either, if you've got that rapport with him, that's great, and as a treating health professional, you might have that rapport where he's going to be honest, and it might even be a matter of seeing if he wants to speak to you on his own, if there's things that he doesn't want to sort of bring up in front of his family, but really, like Georgie and Sally said, you know, like just trying to find out from him what he sees as the problem, and that's going to tell you a great deal, because if he doesn't see a problem, then there's a good chance that there's probably not so much of a safety issue. But if he's balking, well, you know, there could be other issues there.
Sally, did you have anything to add to that?
to find out whether there's a safety issue, sometimes it's just easier just to name it. Like, obviously, if you're having a conversation with him, I would say something along the lines of, like, you're not thinking of doing anything silly, are you? And that generally, it's asking the question in a roundabout way, or if he was struggling to engage, obviously engaging with an Aboriginal service that could get that information out of him, or an Aboriginal group that a lot of Aboriginal people too might not want to be linked with an Aboriginal organisation. So it's always important to make sure that that's the way they want to go, rather than mainstream too, because there also is a lot of dynamics that go on between our Aboriginal community too. And he might just have a new friend group because he's moved to a different area, and just be about exploring whether they're positive role models or negative role models as well.
Yep.
So we've got a youth drug and alcohol team, which I would probably end up, if he was engaging, then you could refer to him for some case management through our youth drug and alcohol team, and then they can explore further what's going on for him.
Georgie?
On top of what Ray and Sally said, I want to know if there's significant drug and alcohol issues in the family, intergenerationally. So if there were, or perhaps mum and dad may have had some, who knows, which may be in their interpretation of him going up the rails, I think that increases the risk a little bit. And if there's a history of significant drug and alcohol suicide within the family, then I think that changes it. So I just want to explore family history a little bit more, because that would definitely help with my risk assessment.
One of our audience members has just asked what you think about checking with his younger brother, or I guess the idea of checking with other family members, checking in on him. What do you think about that? I might ask you first, Sally.
I think it depends what sort of engagement you've had with him within the first couple of sessions, and whether he's happy for you to discuss anything with his family. You'd always have to check. You couldn't just go and discuss something with his family without his permission, or like do a safety check without his permission anyway. So it would definitely be something you'd have to discuss within the first couple of times engaging him. Yeah.
Just with Josh's pop having passed away quite recently, George, did you want to say anything about how you would approach that with him?
Yeah, I want to know, again, it'd be the exploration of relationships and the meaning of that for Josh. Who did pop signify within the family? What knowledge, what cultural knowledge did he have? What was the meaning of that loss for Josh, and what was the impact on his parents for that as well? Is there a conversation in the family about that? Are people talking about the grief and the loss? Yeah, and what did pop signify? You know, sometimes relationships can be healthy, strong ones. Sometimes they can be dysfunctional, disrupted ones. But even the loss of a disrupted, dysfunctional relationship can have a significant impact, especially too with a lot of Aboriginal people. Sometimes the secrets go to the grave. So there can be some missing knowledge and some missing stuff. So again, explore what did pop mean to you? What does that mean for your family?
Great. Someone else in the audience has just asked about when we're doing a safety check about using direct language versus using that indirect language of, are you thinking of doing anything silly for our Aboriginal and Torres Strait Islander patients? Did you have anything to say about that, Georgie?
I'm with Sal. I think be direct. I think particularly with young people, if you use the term silly, that could mean a range of things. So have you ever had thoughts of just ending your own life? Have you ever had thoughts of hurting yourself? Do you know of anyone that's ended their own life? Has anyone around you or in your family done that? I think be upfront, and then it gets rid of any misinterpretations or assumptions.
Yeah. So, and I guess it would depend partly on the relationship you have and with that person about, but it sounds like direct is the way to go.
Yeah, and sometimes with young people, you can just say other people are concerned. You can say, you know what, other people in your life are concerned. Why do you think they're concerned? And you can say that, they go, I don't know, there's no problem, which sometimes they do. Say, well, some people in your life are concerned. So why do you think they are? Get them to think about it.
You've mentioned, Sally, some of the services that might be appropriate for Josh, depending on what we find when we ask him more questions. Did you want to talk a bit more about the different services that might be places that he might be interested in engaging with?
So community access hubs, down here on the Central Coast, we've got GNL, which is a youth drop-in centre. They have lots of different activities on most afternoons. They've got, you know, guitar lessons, they've got dance lessons, and all of it's free of charge. They've got a youth drop-in program where they have like a different health, like they do health promotion there on a Friday night. With health services go in and discuss some harm minimisation tools and some other issues that may be going on in the community. The NRL, I know that they do obviously that Indigenous school program where they encourage Aboriginal kids to continue at school by giving them free tickets to the NRL. Obviously Chase the Energy and some other online resources like WellMob, AHMRC have great references and toolkits. They've also got like a youth conference that they have going on that maybe workers could link in with, youth workers they could link in with to get some more tools and things if they were supporting him. And obviously your room has got lots of quizzes and tips in regards to drug and alcohol use and what that means, and some harm minimisation strategies on there as well, because I know that the youth are going quite digital these days.
And Georgie, have you got any tips about asking Aboriginal and Torres Strait Islander people about alcohol and drug use? Is there anything we should be doing with our language?
That's an interesting question. There's a lot I've met, you can tell when they walk in the door. I just ask again basic questions again, just like anybody else. You know, you smoke the yardy on the piss. You know, do you have the grog? Keep it relaxed. Don't keep it formal. Don't make it clinical. Just have a chat around it. You know, and if, you know, sometimes it's a big thing in families and stuff as well. But just keep it casual. Sometimes I say to them, you know, I'm not the drug and alcohol police. I'm just here to figure out what's going on for you, and just keep it relaxed, I think is the thing. If you know the slang words and you know the terminology, use it. Can sometimes just help you seem like not a big bad parent. You know what I mean? Keep it relaxed.
Keep it relaxed and don't be judgmental.
Yeah, and the other thing I found too is that some of them don't even know what the drugs actually are. Like, I remember working with one Aboriginal woman that used to shoot up fentanyl patches, and she actually didn't understand what fentanyl actually was and what the risks were. So also don't assume that they have a lot of knowledge around what they're using either and what it's about. So if they do open up to you and tell you what they're using, you know, just ask them questions around it to see if they actually understand the risks and the stuff associated, because often they don't. Yeah.
Now, if we were to find out in this case that Josh was actually unwell, and you know that he was sick and maybe at risk and maybe needed an escalation of services, what sort of things might I need to think about in terms of like cultural concerns if we were thinking of involving special services?
Oh, sorry, you cut out a bit.
Oh, didn't hear the question.
No, yeah, you cut out a bit.
Sorry, I'm talking away. I'm just saying, can you hear me now? Yeah. If Josh were more unwell than we initially thought, and we thought we were needing to escalate services so that he might be at risk, might need to seek some specialist care, like mainstream specialist care, or might need to go to a hospital, what are some of the cultural concerns for him? Did you want to start, Ray? Oh, sorry,
Okay,
Georgie.
sorry.
No, you're right.
I know, like this is Georgie and Sally's main area, but as far as I'm concerned, like I work in with the AMS system, the Aboriginal Medical Service system, so we'd put it through into the Sue section, and they would take it on board from there. But yeah, the girls, did you want to sort of add to that?
So obviously if he was coming into an acute setting, I'd just link him with the Aboriginal health worker, just to ensure that he knew everything that was going on and what the process would be. Obviously make sure that the family knew what was going to happen for him, and just check where he was more comfortable in getting an admission also, like whether that be at home in Tamworth or whether that be in Newcastle, as his family are going back and forth. A lot of Aboriginal people do feel more connected and to heal at home, so he may prefer to have the admission in Tamworth. You just don't know. So I'd just explore that with him as well, and then working with an Aboriginal health worker to make sure that he was getting any cultural needs met while he was in the ward.
Yeah, and I think he's 18 too. I'm not sure what your headspaces have up there in Newcastle, but I know down here we were linking in with Aboriginal workers and Aboriginal organisations. So Headspace isn't a bad place to fall either, because it's youth friendly. And I think one of the downfalls in our system, in our acute services, is we take them 18 years and older, but they're not particularly friendly for young people. And I think they can be really traumatizing environments. So I'd rather go low and slow, as I'd say it, and perhaps connect in with the Headspace first, just for that young person's approach. And they should have an Aboriginal worker or linkages in there. They should.
Great, great advice. Yeah, they do, and yes, they're available. Yeah. Great. Did you guys have any more questions? I think it's likely we'll finish a little bit early this evening. Did you guys have anything else, any other questions or any other things you wanted to add to this case? No. Beautiful.
I just think that, like, I get asked all the time by health practitioners on, how to provide culturally safe treatments. And I think just listening to everything tonight, I think that this is something that would go a long way towards that across so many different fields.
Yeah, and I think you've got the double whammy of it being an Aboriginal and a young person. And working with young people is quite specialised too. You've got to have that engagement with young people too. So you've got two kind of types of engagement going on, as well as with the family. So I just think, again, like being collaborative and working across those different areas is really important.
And one of the things that all three of you have talked about are, like, in your talks, it's about building on those strengths of, connection to culture and connection to family, those kind of strengths that, for this young fellow, and you've all talked about in this talk as well as the importance of engaging with him, ways to engage and ways to be culturally safe in your communication.
And just listen. Like we, a lot of health workers can fall into the trap of just presuming they understand what life might be like at home for this person because they've read books and they've seen TV and the media and that sort of stuff, and it's never the case. It's just not the case. And so just ask the questions and listen, actually, and believe what they're telling you. They've got no reason to lie to you. You know what I mean? If they're seeking help.
Yeah, and the other thing you've all said is that there's a lot of resources out there for all of us to access if we're not sure, and a lot of services that are available for Aboriginal and Torres Strait Islander patients. So that's great. Thanks. Are you still there, Kathy? Hello, we finished really.
Yeah, no, I'm still here. Thanks, everybody. That was really good. It was fantastic. I'd just like to let everybody know that a copy of this webinar will be available on our website in our education resource library. I think that's all for tonight. So we'll catch you next time for the next webinar. Thank you.
Thank you, everyone. Thanks, Anita, for that.